A very good evening to all. Welcome to our next episode of Clinical Capsule for our dear postgraduates as well as for our dear members. We are sorry our President Dr. Rajeev sir is unable to join this meeting due to some inevitable family problems. Please excuse. So now let me welcome and introduce the speaker of the day, Dr. Ramya Adasheri, to our PGs. She is pediatric ophthalmologist from Pioneer. She heads the pediatric ophthalmology, strabismus, and neuro-ophthalm services at Pioneer Cooperative Hospital. She's an academician. She did her MBBS from Government Medical College, Kozhikode, Masters from Minto Eye Hospital, and her fellowship in pediatric strabismus and neuro from Narayana Nethralaya, Bangalore. She's a fellow of Royal College of Surgeons, Glasgow, as well as a member of Royal College of Surgeons, member from Edinburgh. She has many awards and publications, both at state and national level. I know it's a big task for all of us to assess a strabismus patient, especially being the pediatric age group. So I'm sure after this talk, it will benefit all of us. With these few words of introduction, I welcome Dr. Ramya for her talk on how to perform a effortless and proper squint assessment. Over to you, Dr. Ramya.
Thank you, ma'am. I'll just share my screen. So, good evening, everyone. First of all, I would like to sincerely thank our President, Dr. Rajeev Sukumaran sir, Dr. Sujit sir, and Vijayalakshmi ma'am for giving me this wonderful opportunity to interact with all of you today. When Vijayalakshmi ma'am told me to take a session on the examination of squint, I readily accepted because this is a topic which is very close to my heart and I genuinely love and enjoy teaching. For many of us, when we hear the word squint, it immediately sounds very complicated. And even in general ophthalmology practice, when a patient with a squint walks in, the first thought can be, let me refer this patient to a squint specialist. But actually, squint examination is much simpler than it appears. You don't need a lot of high-end equipment. What you really need is a systematic approach, a few important examination techniques, and an understanding of what you are looking for and why you are looking for it. So, through today's session, my aim is very simple. I want to take away that feeling of squint is complicated and replace it with I know how to approach this patient. So by the end of the session, I hope that when you see a patient with squint, you feel confident enough to examine the patient yourself, identify the important finding, and understand when you can manage the patient and when you need to refer. So let's make the squint examination simple, systematic, and hopefully enjoyable today. Okay. So I hope my screen is visible and I am also visible and audible. Okay, sir. Shall I start?
Yes, Ramya.
Yeah. Okay. So before going to the squint, we should know what is a normal alignment. So what happens is normally the two visual axes intersect at the point of interest. So what is visual axis? Visual axis is starting from the fovea to the object of regard. So when usually what happens is the two visual axes intersect at the point of interest. But what happens? It's not moving. Yeah. What happens when one eye is not aligned? So look at this image, the red image. So here from the right eye, from the fovea to the object, that is the visual axis, it falls on the image. But the other fovea is looking at a different image. So that will lead to confusion. So this is the principle of our Hess chart. Whereas what happens with this image? This image is seen by the extrafoveal element of the deviated eye. So that will lead to diplopia. So this is the principle of diplopia charting. So I hope all of you understood that what is a normal visual axis and how does it, what happens when it is deviated. Yeah. Now coming to the classification of strabismus. Strabismus can be a latent strabismus or a manifest strabismus. Latent means it is latent. It is there, but it is hidden. So otherwise it is known as a phoria. It is not present when you see the patient. But some of your techniques will find out whether it is there or not. And whereas manifest strabismus means you can see that. So this manifest strabismus can be either a constant one, that means it is present throughout the time. Whenever you see the patient, one eye is deviated or other eye is deviated. Whereas intermittent strabismus means it is there sometimes, it's not there sometimes. Sometimes when you see the child is ortho, sometimes when you see the child is squinting. So that is intermittent squint. And it can be either monocular or alternating. Monocular means always one eye is deviating, always the right eye is isotropic, or always the left eye is exotropic. It is because the child is fixing with only the other eye. That is monocular squinting. This is important because alternating means it alternates. When the child is fixes with the left eye, the right eye is deviating. But when the child is fixing with the right eye, left eye is deviating. The importance is that in an alternating squint, there won't be amblyopia. Whereas in a monocular squint, the deviating eye will be, most of the time, it is amblyopic. So that is the importance. So now coming to the examination part. So I will go in this order. This is how you should see a patient. It starts with a history and inspection. The squint examination usually starts as soon as the child enters your room. You have to know inspection is very important. And in children, you may not be able to do all these tests in an order. Sometimes you may have to combine one with the other because children are not very cooperative. Sometimes, so you have to do some history with a sensory examination like that. So, but the order is like first history and inspection, then the sensory evaluation. Always you have to do sensory evaluation before your motor evaluation. Why? Because once you break the fusion, you won't be able to get your sensory evaluation test proper. And once you got the motor evaluation, you know this is the squint. Now the next part is your management. So to manage squint, you have to know what is the measurement of the strabismus. And any of the squint examination is complete unless you do a complete eye evaluation, including anterior and posterior segment evaluation, cycloplegic refraction. And some of these examinations also need some special tests. I hope PGs are joined. So in between, I will ask you to open the chat box and type whenever I ask questions. Okay. So it starts with history. So in a squint case, you have to know when is the onset, to know whether it is a congenital onset or before congenital or later, and the progression of the squint. As I told earlier, whether it is a constant or an intermittent one, is there any history of double vision and associated complaints like headache. Now, in a child, you have to also know the antenatal events, the birth history, whether it is a preterm or a term baby, mode of delivery, NICU admission, respiratory distress syndrome, and developmental milestones. Any family history of consanguinity, squint, refractive errors, all you need to know, and past history of similar complaints. The child may be wearing glasses, he may have taken treatments like patching, or he may have undergone a surgery for a previously a squint, and any eye drops he is using. Then medical history for neurological problems, acute illnesses, and any other drugs. So I cannot overemphasize the vision assessment as well as cycloplegic refraction in any case, because you have to check the age vision using age appropriate methods, and a cycloplegic refraction is a must, either using a cyclopentolate or a hometropin or atropine sulfate. Why? Because just see this case, you can see when I showed this accommodative target, the child is squinting. But when I showed this, when I gave this, he was hypermetropic. He is wearing hypermetropic glasses, and now he is not squinting. So hypermetropia can present as an esotropia. So a simple refractive error management is the treatment for this case of squint. as well as this child, she has come with an intermittent exotropia and she was myopic. When we gave the glasses, she is ortho. So this is the importance of cycloplegic refraction in any case of squint in all children. So how to diagnose amblyopia in a pre-verbal children? So you may not be able to do all the tests in a small child, very pre-verbal child. So then how can you tell whether the child is having amblyopia in one eye? So as I told earlier, in a monocular squint, that is constantly deviating eye, or on occlusion of the non-deviating eye, that is the fixing eye, if the child, the deviating eye doesn't take a fixation, that means it has a very poor vision in that eye. And if the child is resisting to occlusion. I'll show you one video. You can see when I cover the left eye, the child is comfortable. He is watching the video. But what happens when I cover the right eye? He is resisting my occlusion. That means he has poor vision in that other eye. Now, coming to the inspection. Inspection, when it starts when the child enters your examination room. So it has, you have to look at the head posture. Head posture has three components. That is either the head tilt, whether it is to the right or to the left. Then you have to look for the face deviation either to right or left, and chin up or down. These are the three parts of head posture. Then any facial asymmetry is there, any palpebral fissure, a lid position, and any nystagmus. This is all you have to observe. I want any one of you to unmute and tell me what, with the first image, what you are observing. Sorry. Yeah. Anyone, please?
In the first picture, there is a chin down posture.
Yeah. Yeah. There is a chin down posture. Second
Second
picture.
one, there is chin down, right head
Yeah.
tilt and left face turn.
Yeah.
On the third, the child is having a right face turn with right eye going into E. So the left eye must be taking out the fixation. And
Okay.
the last picture, the person is having a right face turn.
Normally, what happens is when the squint is divided into comitant squint. I think I missed that slide. Comitant squint and incomitant squint. In a comitant squint, the amount of deviation will be equal at all gaze positions. Whereas in incomitant squint, what happens is it is different in different gaze positions. Incomitant can be either a paralytic squint or a restrictive squint. So even though the first child, he was esotropic, but there is something called a pattern strabismus. It's a type of incompetency in a case of comitant strabismus. So you have different amount of deviation at different positions of gaze, especially up, down, and primary gaze. So this child is having is a pattern esotropia. That's his pattern A pattern. Sorry, V pattern is esotropia. So his it is more in the down gaze, so he wants to make his eye up. That's why he is having a chin down posture. Whereas in the left, the second image, have you noticed the blonde hair of this girl?
Yes, madam.
Yeah, so she had nystagmus. She has albinism and so pendular nystagmus. That's why to keep the eye in the null position where the nystagmus is minimal, she is turning the head. And the third image, this girl, she had superior oblique palsy. And this man, he has a right gaze palsy, so he is not able to make his head to the eyes to the right side. So he is keeping his eyes to the left side by turning the face. He had a spontaneous hemorrhage due to hypertension. So this is the importance of
I have a doubt.
inspection. Yeah.
Can we comment on a pattern with a photo, or like the first child had a pattern?
No, we can. I mean, but you can. If they ask, you can tell what is it. I mean, what is the cause of chin down posture in this child?
Okay.
So then you can tell this could be the cause for this pattern strabismus could be the cause for chin down posture.
Okay, madam. Okay, madam.
Okay. In an A pattern, ET will be more in the up gaze. In V pattern, ET will be more in the down gaze. Yeah, means vice versa in the exotropia. Why this is not moving? Slides are not moving. Yeah. Now, anyone else want to tell about this image? Anything you observe in this case? Anybody, please unmute yourself.
Left side is kind of hypoplastic with.
Yes, exactly. So you can see if you draw a line from the lateral canthus to the other lateral canthus and along the angle of mouth, you can see the left side is less developed compared to the right side. So she had a right superior congenital superior oblique palsy because of the constant head tilt. Her left side is hypoplastic. Very good. And this boy, you can see the right eye has ptosis, right?
Yes.
Yeah, but don't look at the ecchymosis. You had come with a fall, but I just want to concentrate on this Squint part. So when I cover the left eye, what happens? When he is fixing with the problematic eye, so that time the squint disappears. It was hypotropic, but the squint disappears, and sorry, not squint, sorry, the ptosis disappears. That this is called a pseudotosis in the case of monocular elevation deficit. Okay, so you have to observe the palpebral fissure also. Now, just see this image, this picture. Only Vaishna is there. Anyone else? Okay. Anyone, please.
DRS, madam, left eye.
Yeah. So yeah, here the palpebral fissure widens on abduction, whereas it narrows on adduction in both eyes. So it's a case of bilateral Devon's retraction syndrome. So this is the importance of inspection in any case of squint. Now coming to the sensory evaluation. Sensory evaluation, you have mainly three tests: Bagolini striated glasses, stereopsis, and Wirth-Fodor test. So here you have to go from the least dissociating to the most dissociating. Okay. So as I said, sensory evaluation should be before the motor evaluation. So here also it should be from the least dissociated to the most dissociated. So Bagolini striated glasses, these are striated glasses which are placed on both eyes, right eye 135° and left eye 45°. And you will shine a pen torch and tell the patient to see how he or she sees. So normally in a bifoveal fixation, what happens? You will see a cross. Whereas in a case of esotropia, you will see V pattern, and exo you will see A pattern, and suppression, if one eye is suppressed, you will see only one line. And in a microtropia, you will see a cross, but with a gap in the center. So this is Bagolini striated glasses. Now, next test is stereopsis. Stereopsis, ideally, you have to do for distance as well as near. But most of our clinics doesn't have a distance stereopsis chart. This is one of the distance stereopsis chart where the patient wears the red and blue glasses, and it's a computer-based screen. So the one image will be popping out, and the patient has to identify which one is popping out, and the stereopsis will be seen on the screen. This is stereopsis for near. Which chart is this? Vaishna?
Lang, first is TNO chart, the butterfly.
No. It's
No.
Titman.
Lang, Titmus flight test.
Yeah. Titmus flight test. Here the patient wears what type of glasses?
Polaroid.
Yeah, Polaroid glasses. And this is the gross stereopsis that fly on one side, and the other side you have animals in A, B, C rows, and one of the animal will be popping out from the surface of the book. So she has to identify which one is popping out. Depending upon that, you can quantify the amount of stereopsis. And the upper one, that the buttons, there also out of the four, one will be popping out, and that will be giving the fine stereopsis. Okay. So similarly, you have stereopsis for near for this test also. This is TNO test, which uses, instead of Polaroid glasses, the red-green glasses. Now coming to the Wirth-Fodor test. This is the most dissociating test Here, the patient wears right eye red glass and left eye green glass. And we shine a torch with these 4 lights from a distance of 33 centimeter, and the patient, it has to do actually for distance as well as near, and the patient has to tell whether it is how he or she sees. So normally what we see is binocular single vision, you will see one red and 2 green. Whereas if you have a left suppression, you will see only red. Right suppression, you will see only green. And in the diplopia, depending on whether X or ESO, you will get 5 images. So that is the sensory evaluation. Now we come to the motor evaluation part. So motor evaluation part has power tests, versions, ductions, and versions. Okay. So what are the prerequisites for doing a cover test? If the patient is having very poor vision in one eye, you cannot do a cover test. And you need to have an accommodative target for distance as well as near. You cannot do it with a pen torch. And the patient has to wear a proper correction in place. That's why I've told you have to do a cycloplegic refraction and give the correction, and then only you can do a cover test. This test. So before doing cover test, you need to know apparently which eye is fixing and what is the deviation. So for that, you have what is called as the Hirschberg corneal reflex test. So normally what happens when you shine a torch, the reflex falls on the center of the pupil. So in this, the central one, you can see the reflex almost falls on the center of the cornea. So you call it, you may think that it is a case of it is a case of orthotropia. But what happens with the first image? First image, the reflex falls
Near the limbus.
nasally or temporally?
Temporally.
Yeah, it falls temporarily. So, yeah, it falls temporarily means the eye is inside. That's why it falls temporarily, right? So we can say the child is fixing with the left eye and the right eye is isotropic. Whereas in the third case, it falls nasally. So this is exotropic. The down one, here the reflex falls down. So the eye is hyper. Down means it is hyper. And up means it is hypo. I hope you understood.
Yes, ma'am.
Yeah. So in this case, can you describe this case? So actually, it looks like a case of esotropia, right? You can see the white part in this eye is seen well, but the white in this side is not seen well. But is it actually an esotropia? You look at when the child is looking towards the right side, what happens is this cornea is seen fully, but this cornea is seen, it's partially hidden inside this fold, right? And similarly on left gaze. So actually these are the epicanthal folds. So this, and you can see there is a broad nasal bridge. This is a case of pseudo-esotropia. Oh, so what are the causes? Normally, there is an angle that is called as angle kappa between your visual axis and the pupillary axis. So visual axis is from your object of regard to the fovea, whereas the pupillary axis is the one which is going through the center of the pupil. So normally there is an angle. So if you look at many of your patients, you can see the reflex is falling not exactly at the center. It falls slightly nasally. So it looks like a slight exotropic look, most of these patients. So that is because of the normal positive angle kappa. But what happens if this positive angle kappa, it's even more, the child will be having an exotropic look. So that is known as pseudo-exotropia. But I'll tell you that. And if it is on the other side, you will call the negative angle kappa. So negative angle kappa will give rise to a pseudo-esotropic appearance, whereas the positive angle kappa will give rise to a pseudo-exotropic appearance. So this large positive angle kappa without other abnormalities you can have, or it can also be due to a temporal dragging, as in the case of ROP. This child actually, it looks exactly like a exotropic, right? But it is not. And sometimes a wide IPD can also give rise to a case of exotropic look. Whereas in esotropia is due to negative angle kappa wide epicanthus, as in this case, and prominent epicanthal folds and narrow IPD. Then how do you know whether it is means this is exotropia? The patient comes with the parent comes with the child is having squint. Then you have to tell that it's not squint. So the next examination is to confirm whether it is a squint or not. You have to do a cover test. That is the that will tell you whether it is a pseudo exotropic or it is a orthotropic patient, means exotropic patient. So cover test. So cover test has three parts. One is direct cover test, then cover uncover test, and alternate cover test. So cover test means you are covering one eye and you are looking at the other eye. So you are looking at whether the deviation is there or not. So actually it is testing your manifest deviation. When you cover the right eye, you are looking at the left eye, whether it is coming out or in, going out, coming in, like that. So this is testing your manifest squint or tropia. Whereas if you are if you do cover test, there is no movement, but you want to know whether there's a hidden squint. In that case, you have to look at the eye under cover. So that is whether it is there inside, but it's not manifested. So that is your phoria. That you come by your cover uncover test. Then if you want to know both tropia and phoria, then you have to do a cover uncover alternate cover test. The thing is that when you do a cover test, you are covering one eye, you should move the your occluder in such a way that you should give time to fuse in between, because you should not break the fusion. You should cover like this, take this and give time to fuse, and then cover again. Otherwise, you should not do like this, because then you are breaking the fusion. So then you may be mistaken a phoria as a tropia. Okay. Okay. So any one of you, please tell me what I am doing and what is the what are you observing? Is it a tropia or a phoria? Yeah, tropia. So when I am covering the apparently normal left eye, because my Hirschberg test tells me that the left eye is the fixing eye. So which eye I will cover? The apparently normal fixing eye. So I will cover the left eye and I will be looking at the other eye, that is the right eye. So right eye, what happens? The right eye is going out and taking up the fixation. That means the eye was inside before. So the right eye was esotropic. But what happens when I uncover it? It comes again back to its normal position. It is not able to maintain the fixation. The right eye is not able to maintain the fixation. That means the child has always right eye esotropic. She is not alternating. Similarly, in this case, you can see when I cover the right eye, the left eye is coming in and taking up the fixation. And when I uncover, it goes back. So that means he is having left eye is exotropia, but in between for some time there was mild alternation, but otherwise he is left eye exotropic. Okay. Similarly, in this case, when I cover the right eye, the left eye comes in and takes the fixation. So this is a case of left eye hypertropia. And here, when I cover the left eye, the right eye goes up. And takes the fixation. So the right eye is hypotropic. Scenario, you can see both eye looks normal. Are you able to hear me? My internet is unstable.
Yes, ma'am.
Yes,
Ma'am,
yes,
can you
ma'am.
hear?
Yeah.
Yeah. Okay. So now you can see I'm covering, I don't know which eye is normal. So I'm covering apparently normal. Both eyes are looking normal. So I'm covering one of the eyes. Now I'm looking at the other eye, there is no movement. But what happens? The eye under cover, it is going in. So actually, just once more, yeah, you can see the eye under cover is going in. So that means it is esophoric. Similarly, in the second case, you can see when I cover the left eye, you can see under the cover, the left eye is going out. So this is exophoria. So this is how you know whether it is a phoria or a tropia. And when you do alternate cover test, you will get both tropia as well as phoria. So in a patient, if you do alternate cover test first, what happens is you may mistake a phoria as a tropia. So that is the now intermittent divergence. So this phoria, in the case of a large phoria, can give rise to what is known as intermittent deviation. So sometimes the patient is able to control, but sometimes the patient is not able to control. When the fusion is broken, the child will be manifesting. When the fusion is good, child will be normal. So depending upon the control, you can have intermittent divergence with a different control that you need not know. There is something called an NCS score where you can grade the amount of squinting. In an exophoria, what happens is when you cover, it immediately comes back and takes a fixation. But what happens in IDS is that it will take some time to come and fix it. It will come, but it will take either slowly or with a blink, or it will not even come with a blink. So this is how you grade whether it is a good control, bad control, like that. So this eyes has gone out. But with a blink, she has taken back it to normal. So that is IDS. Now coming to the next part, that is ocular motility. Ocular motility has three things. One is version. What are versions? Versions are binocular conjugate movements. Conjugate means it is moving in the same direction, either to the right or left or up or down. It is conjugate. Whereas ductions means you cover one eye and you are looking at one eye. That is monocular movements. And vergence means it is disjugate. That is in different directions. That is binocular disjugate. Either it can be a convergence or it can be a divergence. Okay. So versions you have to means normally in a comitant squint you will measure it for means all the squints you will measure it for all 9 positions. You have a primary gaze, then up, otherwise known as supraversion, then down infraversion, then up left, levo elevation, dextro elevation, levo depression, dextro depression. These are the 9 positions. I'll just show you how will you test. You just show it target and move the target to one side. So now you have to say levo version, then levo elevation, supraversion, dextro elevation, dextroversion, levo depression. This is how you test your versions. Any one of you, please unmute and tell me what are the muscles acting in supraversion? Normally, in a supraversion or elevation, what are the muscles acting?
Superior rectus and inferior oblique.
Yeah, superior rectus, then inferior. Sorry, inferior oblique. Down, inferior rectus and superior oblique. This side, which muscle is acting in the right eye and which muscle is acting in the left eye?
Right eye lateral rectus, left eye medial rectus.
Left eye medial rectus, good. So this is how, now this side, similarly, right medial and left lateral. This side, dextro elevation, which muscle, which eye? Fatima?
Right superior rectus, left inferior oblique.
Very good. Right superior rectus and left inferior oblique. So, you know, the superior rectus elevation action is maximum in abduction. And inferior oblique Sorry, yeah, abduction only. And inferior oblique is maximum in adduction. Why? Because your muscle axis and the orbital axis comes in the same direction, right? So there you have the maximum amount of action in of that muscle. So similarly, here right inferior oblique and left superior oblique, and here right inferior rectus and left superior oblique, and right superior oblique and left inferior rectus. So whenever you get a 9-gaze picture, don't just jump and tell the answer. See the primary gaze, what is there, then look at the left gaze, right gaze, then up, down, like that. You have to go in a manner, then only you will get the answer. Otherwise, you will be confused to see the images. Now, otherwise, then you will get the answer properly when you go in that order. So your oblique action you will test in the adducted position. So here I can, whether if this eye is going up, then I can tell there is an left inferior oblique overaction. If the eye is not moving this much, then I can tell there is a left superior oblique underaction. So your oblique action you will check in the adducted position. Now, grading of this extraocular movements, you have to grade whether after reduction. Sorry, this slide should have come next. So you have to do whether it is -4, -3, -2, -4 means the eye is not moving from the center. So that is -4. If it is moving only this much, then you will call it as -3. And if it is reaching near the canthus, then you will call it as 0. So in between, you will grade like this. Similarly, for the obliques, you can if it is under action, this is the 0 position. Then from that you will get -1 to -4, and if it is going up, you will get a +3 to +1 to +4. So here you can see when the child is looking to the left, what happens? The right eye is moving in like this, but left eye is up shooting. So that means, and here also, so this child has a bilateral inferior oblique overaction. Previously, I have told you about the pattern strabismus. So I'll show one case. So this girl, she had a exotropia. So now just see this child when the child is looking up and down. So this is the primary position. When she is looking down, the exotropia is less actually. And when she is looking up, it is increasing. So the eye is like this. So she has a V pattern exotropia. It is less in the down gaze and more in the up gaze. So similarly, in this case also, this child had a exotropia, but it is more in the up gaze. So when will you call it as a V pattern? If the amount of deviation is more than 15 prism diopters from 25° down to 25° up gaze. So you have to measure it down and up and see whether one is 20 and other is 40. That means there is a 20 PD difference. So it is more than 15 PD. So that means it is a V pattern. Whereas in A pattern, what happens is A pattern here it is 10 PD only. If you get 30 here and 20 here, it is A pattern. So that means divergence of eyes more than 10 PD from 25 to, that is the difference between A and V. So one is 15, more than 15 PD. A pattern is more than 10 PD. So V pattern is usually due to inferior oblique overaction. This boy, he had an exotropia, but he had, you can see the oblique is right inferior oblique overaction. Can you see this?
Yes, madam.
Yeah. And when you look at,
Over-elevation.
yes, over elevation in adduction. So that means his inferior oblique is overacting in both sides. So that's why he had a V pattern exotropia. So the importance is that not only you have to correct the exotropia, you have to correct the pattern also. So you have to do either a recession and resection or bilateral recession. Along with that, you have to do an inferior oblique recession also in this case. That is the importance. Now, ductions. Ductions means when you cover one eye and look at the movement. You have to see adduction, abduction, then elevation and depression. So why you have to do that? If the versions are normal, ductions will be normal. But sometimes what happens is, you can see in a case of a essential infantile esotropia, what happens is the child has cross fixation. So you may have a feeling of apparent abduction limitation in both sides normally, because you may think that the eye is not moving. But when you patch and again do the movements, there will be abduction. So you may have mistaken a normal extraocular movements as an abduction deficit if you have not done ductions. So that's why you have to do adductions as well as versions. So now you know what is the squint, what is the muscle acting, which muscle is overacting. You know almost the diagnosis. The next part is your treatment. So you have to know how much I have to do the correction. So that you can do by all these tests. That is, one is the Hirschberg test, then alternate prism cover test, or otherwise known as the prism bar cover test, then simultaneous prism cover test, Grimsky and cyclodeviation measurement. Okay. So I have already described about Hirschberg test. So Hirschberg, you will shine the torch and you will look at the reflex. So normally what they say is 1 millimeter displacement is equal to 7 degree. And each degree is about 2 prism diopter. So roughly what you can say is, if you are getting a reflex on the pupillary margin, you can take it as 15 degree. So that will be almost equivalent to 30 prism diopters. And if you are getting the image in between your pupillary margin and the limbus, you can take it as 30 degree. And if it is at the limbus, 45 degree. This is how you can get a rough estimate of the amount of deviation. But this is not the actual amount of deviation. For that, you have to do the prism bar cover test or alternate prism cover test. But you will get a rough idea. So in this case, if you are getting like this, you can start with about 38 PD and then you can either increase or decrease if you are depending upon the movement. So in a squint specialist armamentarian, these are the main things to measure the squint. That is either the loose prisms or the prism bars. Prism bars in vertical and horizontal directions you will get. And these are the loose prisms. And normally what we use is the plastic prism. This should be placed in the frontal plane, whereas the glass prisms are placed in the frontis position. And always apex towards the direction of deviation. Even though we place it, means like if the child is having an exotropia, you will place the apex towards the deviation. But we always tell in terms of base. So if exotropia, you will tell base in, whereas esotropia, you will tell base out. But if means for easy understanding, you can say the apex towards the deviation. And base down in a hypertropia and base up in a hypotropia. And prisms to be placed in relation to the orbit. So you are in tilt and all, if you are doing, it has to be in relation to the orbital floor. And just imagine you have a large number of prisms. Then you cannot, in a case of esotropia, you cannot just keep one over the other. You have to split it between the two eyes. In the first image, first image in the two prisms I have placed in on both the eyes. In case of esotropia, this is the second one, exotropia. I am keeping it on in front of both the eyes. I cannot stack one over the other. Whereas I can, if the horizontal deviation is associated with a vertical deviation, I can do a vertical over the horizontal, but I cannot do the horizontal, I cannot stack. Okay. Now, how will you check the amount of deviation? So as I told, by Hirschberg test, you will come to know amount of deviation. But especially, what the problem is that in case of an intermittent squint, your Hirschberg will tell you normal. Because you are checking it for near, right? You are shining the torch and the child is having good accommodation and all, it may not be manifested. But roughly you can do with this. Then what you do is you place the prism and you will do an alternate cover test like this and see whether the movement is neutralized or it just reverses. That is your endpoint. You will do an alternate deviation, means alternate occlusion test. So your tropia as well as phoria is covered in this. You will get the maximum amount of deviation. But if the patient is having very poor vision in one eye, so here this patient is fixing with the right eye and she has very poor, she has an optic atrophy in the right eye and she is having a sensory exotropia. So here you cannot do a cover test. So what you can do is a Krimsky test where you will keep the prism in front of the deviating eye. Here in this case, base in because she is having exotropia and you will look at the reflex. This is the amount of prism you need to correct. You can also do by keeping it on the normal eye and look at the reflex. Then it is called a modified Krimsky test. There are other prism tests, but you just need to know the names. One is simultaneous prism test, which is done in the case of very small tropia or a large phoria, as in a microtropia. And there is something called a prism undercover test. Anyone know this name? In which case it is done? Prism undercover test. Any idea? This is done in dissociated vertical deviation, prism undercover. At least you should know the name. Then coming to the cyclodeviation measurement. So in a case of oblique palsy, you can have a cyclodeviation. So now how will you test the cyclodeviation? Here you will keep the Maddox rod on both the sides vertically aligned and you will place the prism or 4 prism diopter in one of the in front of one eye so that the images get separated. And now the patient has to tell. Now I'll show you how she is doing it. See, this is like this. Now there is a cyclo deviation. Now I will rotate the Maddox rod in such a way that whenever she is see the 2 lines parallel. So that amount of deviation I will measure it from the trial frame. This is how you will do the cyclodeviation. This is important case of superior oblique palsy, bilateral superior oblique palsy following trauma and all. You may need to correct the deviation. So another way you can see the cyclo version is your torsion. So normally what happens? Your macula is in the lower 1/3 of your disc. But if it is more than that, you will call it as an extorsion. And if it is going above this, you will call it as intorsion. In inferior oblique overaction, you will get an extorsion, as in the case of a superior oblique palsy. Okay. Now, any of these examinations or squint is complete without your other examination. You have to get a vision checkup, cycloplegic refraction, slit lamp examination, the cost for a squint, and dilated fundoscopy. In the first image, this patient presented with an esotropia, but on dilated fundus evaluation, she had papilledema due to idiopathic intracranial hypertension. So the cause for the esotropia is because of the false localizing false LR palsy. So that's why it's important to do a fundus evaluation. And in this case, the patient had an exotropia. On examination, he had a left eye toxoplasma scar, which was the cause for his exotropia. So don't label the squint unless you see the fundus. Recently, I had a patient with an intermittent exotropia, and the patient was seen by many people, and she has been sent like it is an intermittent XT. She will outgrow that and all. But later, when once the parent was taking the picture or taking the video, she noticed there is a difference in the reflex of the both eyes. Then she came to me, and when I dilated, it was Scott's disease in that eye. That was the cause for exotropia. So it was actually not an intermittent exotropia, benign intermittent exotropia. It was a Scott's disease causing a sensory exotropia. But in her case, it was intermittent to start with. So that's why it's very important to do a complete eye evaluation before labeling any squint. So till now, what I have mentioned, most of it is in the case of a comitant strabismus. So now we have incomitant strabismus. Incomitant strabismus, either it can be a paralytic or a restrictive strabismus. Paralytic means it is due to paralysis of one muscle, right? So paralysis mainly due to 4th cranial nerve palsy, 6th cranial nerve palsy, 3rd cranial nerve palsy. These are the main causes of incomitant strabismus, paralytic strabismus. So this patient, you can see the right eye is esotropic. So look at the extraocular movements. Go from the primary, look up, down, left, right, and tell me what is there.
Primary gaze, ESO is there. Levo version normal. Dextro version. There is an
Yes.
elevation, abduction limitation in the right eye of
Yeah.
-4.
Yeah.
In versions in the levo elevation, dextro elevation and dextro version, it's persist.
Yeah.
So it would be a right LR palsy, probably.
Yes, very good. So this is how you should go. So don't just jump into the image and yeah, this is the right lateral rectus abduction is deficit. Abduction deficit is there. This is esotropia. So the thing is that in concomitant strabismus, the esotropia, the amount of esotropia will be proportional to the amount of deviation. So if you are having a high the limitation is -4, you will get large amount of ET. If the limitation is only -1, you get a very less amount of DT. So it is directly proportional to the limitation of movement. So it's a right LR palsy. And other tests we can do in the case of paralytic squint is saccades. Saccades you have to check in horizontal as well as vertical. So saccades are fast movements. You have to switch from one eye to the other and you will look at the movement. But in a case of palsy day, what happens? There will be floating saccades. So it will not be able to take up the fixation fast. Okay. Then pass pointing. Pass point, normally when you show one object, he will be able to point that. But in a case of a squint, what happens is that he or she will not be able to point that. It will go beyond it. So that is called a pass pointing. Then you have to do a diplopia charting to know which gaze the diplopia is maximum to find out which muscle is paralyzed. Then Hess charting. Hess charting in a case of concomitant strabismus, both paralytic as well as restrictive squint to know the progression, whether it is improving or not. And forced duction test. Forced duction test differentiate a paralytic squint from a restrictive squint. So if the movements are normal, there is no restriction, that means it's a paralytic squint. It's not a restrictive squint. And to know how much energy, how much force is still there, whether it is a complete paralysis or it is a incomplete paralysis, still the muscle has function. That to know that we will do a force generation test. Restrictive strabismus, I told the restriction of extraocular muscles, but here the thing is that out of proportion to the deviation in primary division, sometimes you can have an orthotropic patient with a -4 abduction. So that is the difference between a paralytic and a restrictive strabismus. It could be either mechanical or congenital or acquired. So you can have these types of CCDs, that is congenital cranial disinnervation disorder. These disorders like Duane's retraction syndrome, Brown syndrome, and all. Brown, sorry, there is a spelling mistake. All comes in these CCDs. Whereas in acquired cases, a thyroid eye disease, because of the extracellular matrix deposition, you can have a restriction of extraocular movements. And sometimes tumor sitting on or cysticercosis on the muscle that can give rise to a restriction. Or an entrapment of muscle, as in a blowout fracture, the inferior rectus gets entrapped in the fracture. You can have an elevation deficit. So all these are causes of restrictive strabismus. So the amount of deviation may not be directly, it will not be directly proportional to the deviation in primary position. So you can just see this case. So the child is orthotropic actually. She is orthotropic in the primary position. I'm telling in the primary position. And look at her extraocular movements. She is having a -4 abduction in the left eye. Yeah. So even though she had a -4 abduction, she is orthotropic in the primary gaze. If it was a paralysis, so but she is orthotropic. So this is a case of Duane's. Yeah. Similarly, this boy. I don't know whether the video has. Yeah, you can see there is restriction of limitation of elevation in adduction, but it looks almost normal in abduction. So this is Brown syndrome because the superior oblique tendon sheath is not relaxing when the child is looking up in adduction. So these are cases of restrictive strabismus. And now there are some special tests in Squint. You must have heard these names: Belshowski head tilt test or and Park 3-step test. Actually, Belshowski test is a part of the Park 3-step test, and for prism base out test. So what is here? You can see the hypertropia. He has hypertropia, which is maximum in the left head tilt, whereas it is minimal in the right head tilt. Why this happens in superior oblique palsy? So normally what happens? Normally your eye is straight. You are turning your eyes to the head to the right side. So right side, right is intorting and left is extorting. So what are the intorters of the right eye? Right superior oblique and
Right superior rectus.
superior rectus. So normally what happens is the superior oblique is a depressor, right? Yeah, intorter, but the other action is depressor. And superior rectus is elevated. So this gets cancelled. So normally there is no hyper either in right or left tilt. So because both the actions get cancelled. But if you have a superior oblique palsy, what happens is when you tilt your head, the superior oblique is not working. Then your superior rectus is acting maximum. So the elevation, the hyper will be more in that tilt. That is how you get a more tilt in the intorted position, means the head tilt. Okay. So the Park 3-step test, it has 3 steps. So this test only in a paralysis of a single cyclovertical muscle you can do this test. So step 1 is which eye is hyper. First you find out which eye is hyper, whether it is a right eye or left eye. In the next step you will see whether the deviation is increasing in right or left gaze. Then the next step you will see, so now I'll come to that, I will tell you how it will be done. Then next step, whether it is increasing in head tilt to right or head tilt to left. That is your Belshowski head tilt test. So just see this girl. Which eye is hyper?
Right eye.
Right eye. So right eye is hyper means either the depressors of the right eye or elevators of the left eye is affected, isn't it? So what are the depressors of the right eye? Inferior rectus and superior oblique. What are the elevators of the left eye? Inferior oblique and superior rectus. First step is okay.
Yes, ma'am.
Yeah. Now left gaze. Left gaze means which are the muscles in acting in left gaze? Left side. In this left side, which are the muscles acting?
Left telar and right temporal.
No, I'm asking obliques and recti. So left gaze, no? So left is superior rectus and right is superior oblique. So right eye will in left gaze, left eye will be in abduction and right eye will be in adduction, isn't it?
Yes, ma'am.
Yeah. So in that case, these are the muscles acting in the left gaze, right? Left side, both recti, and right side, both obliques. These are the muscles acting in left gaze. So just see, now we have 2 muscles, superior oblique and superior rectus. Right eye superior oblique and left eye superior rectus. Now next step is tilt. So right tilt means right eye is intorting and left eye is extorting. Left tilt means left eye is intorting and right eye is extorting. So which tilt it is maximum? Right tilt, right? So right superiors are active and left inferiors are active. What are the muscles of the right eye intorting? Superior oblique. Left eye extorters are inferiors. Right eye intorters are superiors. So which is the muscle now?
Right superior.
Superior oblique. Correct. This is how you should do. Then you will come to know which muscle is acting. This is the Park 3-step test. It's easy actually. Once you write it and do it, you will get it. Just think that recti acting maximum in abduction, whereas obliques act maximum in adduction. Tilt, whichever side you are tilting, your intorters are acting. Your intorters means superiors. Thin rad, you must have heard that superiors are intorters, whereas extorters are your inferiors. So just combine those, you will get that correct muscle which is involved. Now last, you have the 4-prism base out test. 4-prism base, sometimes what happens is the patient may present with vision, reduced vision in one eye, and you do all the tests, everything will be normal. Even your cover test may not pick up a squint. So in that case, what you can do is a 4-prism base out test. Normally, what happens when you place a 4-prism base out? So base out means apex is towards this side, no? So what happens when you place the prism, the eye moves in. So according to Herring's law, what happens? The other eye goes out. To keep the BSV, what happens? The other eye comes back, a refixation, and takes the refixate. So that's how normally what is happening. So you put a base out prism in front of your right eye moves in, left eye moves out, left eye comes back, take a fixation. That's what happens in a bifoveal binocular single vision. Now, just imagine my right eye is microtropia. Right eye has microtropia. Now I am placing it in front of my normal eye first. So when I place the base out prism in front of my left eye, what happens? Left eye goes in, right eye goes out, according to the Herring's law. But right eye will not be able to come back to its position. It cannot refixate because that falls on the suppression photon. Okay. Now I place the prism in front of my microtropic eye, that is the right eye. So when I place the prism in front of my right eye, it cannot move. It's not moving because it falls in the suppression scrotum and there will not be movement of either eye. Understood?
Yes, madam.
Yeah. So in BSV, both eye moves, refixates. In microtropia, if you keep in front of the normal eye, there will be movement, but there will not be refixation. But if you keep in front of the microtropic ray, neither eye moves. Okay. Yeah, this is the representation. It is in. I don't want to. I think. You huh?
ഇല്ല അത് ആരോ
ഞാനിതാ അതൊക്കെ
Okay.
കൊണ്ടുവന്നിട്ടുണ്ട് കേട്ടോ എണ്ണയൊക്കെ കൊണ്ടുവന്നിട്ടുണ്ട് അതുകൊണ്ട്
Ankit, please
Okay, so
mute somebody.
that's what I think. Yeah, I have almost covered Squint, but I didn't go in detail in the paralytic and restrictive part. This is actually that's not very important for PGs, but otherwise I covered everything, I believe. Thank
It
you
was
so
an
much.
absolutely wonderful talk. What is it, PGs? What is that occluder's name? That was once asked for Oski.
Yeah, correct.
Vaishnav Fatima Shweda Arkilaria. What is the name of that occluder?
Starts with S.
Spielberg's. അല്ലേ രമ്യ?
Spielman's.
Spielberg's സിനിമക്കാരനെ.
Yeah, Spielman's.
Spielman's. And this time for the PG update, the basic questions were asked: ductions, versions, versions. This was asked. Then for OSCE, they will show that double Maddox rod test. What is being done and which is being tested. These are OSCE questions. If those have not listened to it fully or those have missed it out, please, you have the YouTube link will be available. Please go through it. It will be really, really helpful for your exams. Not only for that, for patient examination also. Anything to comment, Dr. Sujit?
No, but actually my voice is lost. So you please
okay,
carry on.
okay. Rajesh sir and comment ചെയ്യാനുണ്ടോ? PGs, any doubts to be asked?
Madam, നമ്മൾ ക്രിംസ്കി പറയുമ്പോൾ when do we prefer modified ക്രിംസ്കി or ക്രിംസ്കി?
for my surgery, I generally do both, but almost the same. It's not very, means not much difference, but I prefer modified Krimsky for surgery.
But again, that's an exam question, Vaishna. Krimsky is where do you place a prism in front of which eye they usually ask, and in which condition you perform. These are some questions. Then you should not stack, as Dr. Emi has mentioned, the prisms. All these things should be taken into account. And the placing of the, what is Prentice position, placing of the prism when you have a tilt, as she mentioned, in case of orbital fracture. So, if any more doubts? Okay, then shall we wind up? Thank you, Ramya, so much for that wonderful talk. So next session we'll be continuing the diplopia charting, HES charting. So that will be beneficial for the PGs. Absolutely
So much, ma'am.
great talk. I
Thank
really
you, ma'am.
enjoyed it.
Thank you, Ramya. Thank you.
Yeah, thank you, sir.
Okay, then we'll wind up. Thank you, Ramya, once again. And thank
Yeah,
you
thank
all who have joined. Yes.